Good morning and welcome to the December 5th meeting of the Patient Protection Commission. We're going to go ahead and get started. Dr. Khan, I'll hand it over to you.
Thank you very much, Dylan. This is Ikram Khan, Chair of the Patient Protection Commission. A request our new Executive Director to call for the roll call.
Thank you, Chair. Commissioners, please identify if you are present when you hear your name called. I will start with our voting commissioners. Dr. Jonathan Chastain.
Present.
Dr. Mark Glyman.
I'm present.
Dr. Adam Porth.
Present.
And Dr. Khan.
Present.
Sorry. And Dr. Walker.
Present.
I'll then move on to our non-voting members. Insurance Commissioner Ned Gaines.
Present.
Director Stacy Weeks.
Present.
Executive Officer Teresa Karsten. Mark her as absent. And Executive Director Janelle Davis. We'll mark her absent as well. Chair, that concludes roll call and we have a quorum.
Thank you very much. I'll go a little bit out of order from the agenda. I'll bring up the agenda item number 3 first, because I think we all need to know our new staff here who has joined, and to acknowledge and definitely welcome our 2 new staff members who joined the commission. It's welcome specifically Dylan Malov, who has actually in a very short time caught up with everything. I'm really impressed. That was great. And Taylor Ray Gonzalez, thank you very much for serving this commission. We appreciate your service. I will introduce our new commissioner as we get down. So it's public comment. Dylan, you wanted to check if you have anybody online or otherwise.
Thank you, Chair. The second item on our agenda offers an opportunity for public comment. No action may be taken upon a matter raised until the public comment period, unless the matter itself has been specifically included on an agenda as an action item. To provide public comment by phone, you may join the meeting by dialing 775-321-6111. And when prompted to provide the meeting ID, please enter 204-345-574#. Please press *5 to raise your hand during the public comment period to provide your comments. Comments will be limited to 3 minutes per person. Persons making comments will be asked to begin by stating their name for the record and spelling their last name. If you wish to provide public comment and joining by phone, please press *5 to raise your hand. If joining by computer, use the raised hand icon at the top of the screen. Chair, at this time, I see no one wishing to make public comment.
All right, thank you very much. Moving right along. So I would like to now introduce our new commissioner, John Chastain, who's a clinical informaticist. That's a new one for me. Informaticist, is that right? That's
yes,
a new one for me. All right. So we know you have just recently been appointed. Would you like to have a few words for us about yourself, please?
Absolutely. Good morning, everyone. My name is Jonathan Chastain, as mentioned. I'm a clinical informaticist consulting with Nevada Medicaid through the State University Partnership with UNR Med. My clinical background is in psychiatry, but I've completed subspecialty training in clinical informatics, where I've had the opportunity to work on projects involving patient portal access and interoperability initiatives. So I will be serving in the position of a member who is an employee or consultant of the authority with expertise in health information technology and patient access to medical records.
Thank you very much. Could you explain to, at least for me, what is really the informaticist does for my education, for sure?
Absolutely. So clinical informatics is now a subspecialty of clinical medicine recognized by the ACGME, and it involves working with health systems architecture the flow of clinical data through health systems, including hospitals, payers, and providers. We're involved in a lot of different things, including workflow optimization, value-based care, metric development, big data analysis, kind of anything involving transforming data into information and knowledge within medicine.
All right, that's very helpful. Thank you very much. So moving on to our next agenda item, number 4. It's informational. It's in part of your agenda. It's an overview of the Nevada Health Authority. We have 30 minutes allocated for this, and I would request Stacy Weeks, Director of NVHA. Welcome back, Stacy. We haven't seen you in a while.
I know, we've been super busy. Good morning. Thank you, Dr. Khan. It's good to see all of you. Happy Friday. If it's okay, I'll just dive in and then open it up for questions if we would like. And of course, Dylan, please jump in if I miss anything, or at the end, you feel free. Thank you. So real quick, we'll do an overview of the Health Authority, kind of our high level purpose and our structure, mission and our strategies, the commission's role within the Health Authority, and really, I think, strengthening its role going forward. And then our focus areas for the coming year outlined. We're working on a strategic business plan, and then just open it up for questions and discussion. Next slide. So as some of you may recall, or if you didn't, last session, DHHS, which was our Department of Health and Human Services, was split into 2 agencies. The DHS, which is Human Services, is focused primarily on the delivery of human services and the provision of services. And at the Health Authority, we are focused on compliance, oversight to some extent, depending on the market. And then also we are the payer, so Medicaid, the exchange, and the public employee plan. Excuse me, I've had a little bit of a cold, so I'm going to have to drink some water along the way. I apologize. And then also just one of the reasons I think this is also really important is that the state now can take all of these programs and really leverage its purchasing power, buying power with vendors that it has to use to operate these programs, which gives us sort of a footprint now for not only impacting that purchasing arrangements, but the health outcomes of 1 in 3 Nevadans. So under all those markets being under our umbrella, those are the number of Nevadans that we impact in our program. We're very much focused on improving health outcomes, streamlining our programs to get a better efficiencies and shared resources, and really ensuring that we're aligning strategies and best practices and enhancing quality and innovation as we can and move forward. Next slide. So this is our team. And Dr. Chastain is on that team. You just met him earlier. He is part of our clinical advisory team. In our director's office, we have 4 deputies. We have our budget deputy, Lynette Aaron, our chief of staff, who just joined a couple weeks ago, Allison Janko Herzig, Sandy Rubalid. She is now our chief enterprise officer. And then Melinda Southard, some of you may know her. She does a lot of our community engagement, our public workshops. She is over boards and committees, as well as workforce development, and the Patient Protection Commission is under her umbrella. And then we have 4 divisions. Our director's office is designed to support these divisions. That's one of the reasons we brought the budget up to the top, as well as IT and HR. And our divisions are focused on the programs that they deliver. Todd Rich is over our purchasing and compliance, which includes regulatory compliance issues around facility licensure. It also includes our Medicaid Inspector General's office. It used to live under the Nevada Medicaid Division, or otherwise called Division of Healthcare Financing and Policy. We moved it over to make sure it's independent of the program and really focus in on fraud, waste, and abuse around provider payment and billing. And then also, like I mentioned, we have licensure for a variety of health facilities, hospitals, and we conduct safety and quality inspections. Over our Division of Consumer Health is Jennifer Krupp. She is over our exchange, which does has the public option Nevada-born state plans within it for sale this open enrollment. She's also over Medicaid eligibility policy as we work to create what we're calling the Medicaid Express through the exchange. So real-time eligibility with shopping capabilities and plan comparison and network comparison. So we're very excited about that project. But her and Sandy on our team are working hard to get that lifted. Nevada Medicaid is Ann Jensen. Before, a lot of this division was known, as I mentioned, DHCFP. In statute, that acronym has been abolished and it is now Nevada Medicaid. Hopefully we're avoiding acronyms. That's the goal here, is to get away from all the acronyms, but still we find that occurs. But if call it Nevada Medicaid, because that's what it is, and Ann is over that division. She's over our benefits and our policy in the program, rates, reimbursement, federal waivers, community supports, long-term care. All the primary program pieces are under Ann. As I mentioned earlier, the budget is in the director's office, so she can focus on the program side, but obviously there's a lot of coordination between the two. Teresa Karsten, some of you may remember her from Medicaid. She was our deputy administrator over managed care. She is now over our public employee benefits program. She administers PEB, which is also what is referred to as in its acronym form. She does a lot of contracts and performance oversight and vendor relationship, and does work closely with the PEB board. Next slide, please. So our mission is, we've kind of laid out, the statute had a very long, detailed mission and requirements, but we tried to summarize that up and to be a more bite-sized mission to ensure Nevadans have access to affordable, reliable care by leveraging the state's buying power, streamlining our programs, and deriving better quality and more innovation together in the health system. I just really want to highlight the word reliable. I think we can spend all day and get affordable coverage, but if there is no ability for an individual to get an appointment with a doctor or get the care they need, health insurance really isn't healthcare, right? And so reliable is a really important piece of this. Workforce and all the things that our department is focused on is really ensuring that coverage provides reliable access to healthcare. Vision, our vision is just a healthy, thriving Nevada where every resident has access to affordable, high quality care that they can really count on. Next slide. So just a snapshot. I know sorry to be Debbie Downer early in the morning and just point out some of our weaknesses, but when you look at how we're ranked nationally, Nevada, unfortunately, is not just in the bottom 10, the very bottom 5. One of the things that we're really focused on, I know the governor is as well, is just really getting Nevada out of the bottom. We have to do better. We can do better. We know this. And so that's one of the big focuses for us at Nevada Health Authority. As you can see, one of the things I want to talk to you all about today, and I know you guys have talked about in the past, is that for women's healthcare and outcomes for moms and babies, we're at last in the country right now, and even in reproductive health care. Mental health, I think there's no surprise. As you guys know, there's a lot of work in this space going on with our transformation project, with Medicaid. And then obviously, I think very alarming for those of us in public health too, is that we're 51st in prevention and treatment. So as you know, if we're at that bottom there, our outcomes are not only chronic, but they're very costly for the state budget. Next slide, please. We have outlined 4 strategic priorities or goals for our new department for the next 3 years. The first one, I think, doesn't probably come as a big surprise, is improving health as being the Nevada Health Authority, but we really are focusing on what we're calling our key health indicators. Some of the areas I just mentioned where we're lacking in performance, we really want to focus in on strategically creating a variety of programs and activities designed to improve maternal health, behavioral health, chronic disease management, and prevention. Our second goal is to sustain our programs. We can make Medicaid and PEB and the exchange great and cover a lot, but if we can't afford it and we can't maintain that program at the state level, we're not doing our jobs. So we really are trying to make sure that the cost of our programs are sustainable for our state budget. For those of you that may not know, these programs under the Health Authority make up the largest portion of the state's budget next to education. Also, the third item we're focused on is bringing back what I mentioned earlier around reliable care, is growing our workforce. We know that Nevada struggles to get providers, primary care, maternal health, behavioral health, specialists across the board. And that's something we're very much focused on, including implementing the new Rural Health Transformation Program grant, which is about, hopefully, we'll get the full $200 million that we have requested, and we'll be implementing that with all of you soon in January. And then last but not least is really increasing the value for the taxpayer dollar, in addition to the value to the consumer of the coverage that they get and the care that they get. And really doing that through innovation, better coordination, and collaboration and efficiencies in our market. our markets under the health authority. Next slide, please. So where does PPC fit in all this? I think it's a really important piece to the work that we're doing. I'm very excited that Dylan, previously he was the policy advisor for the PPC, has stepped into this role. Dylan brings a lot of knowledge and expertise, and so does Melinda with really engaging the community. And we're really hoping with this Patient Protection Commission that we can really strengthen its role in the state and some of the work that we're doing in healthcare and aligning that work. We appreciate that the legislature and the governor had the foresight to put it within the health authority, and we have put it within the director's office because it is a very important piece and component, and it really doesn't live under one coverage program. It should be looking at all of the programs across the board for Nevadans. One of the things that we really want to drive home is data-driven decision-making for this committee. And I think Dylan brings a lot of those skills to this group. As we also have the Office of Analytics at Nevada Health Authority that we will be leveraging, and also Dr. Chastain and his amazing skills, but to really bring to you all health policy research and recommendations. I did want to note that the Health Authority, we are doing our Medicaid academic partnership with the medical school, which is why we're able to leverage the expertise and the great help of Dr. Chastain and other physicians. But we're also looking at a public health partnership with the universities to help us create a population health management strategy that we would love to really engage you all in as well. And then third is really this evidence-based advisory role. Like I mentioned, the data-driven solutions that you're going to bring forward, and helping align this work with our state priorities, the governor's priorities, and where we know the legislature as well is really focused in that and our mission and goals at the health authority. Next slide. So just really thinking through how do we partner with the committee as well as all of our other work that we're doing with engaging stakeholders to have a greater impact of the recommendations in your time and your work. I know all of you don't just show up here for funsies on a Friday. I think you all are very much committed to the mission and what we're trying to do at the Health Authority as well as the Patient Protection Commission. And we want to make sure that you are getting the information that you need to really feed into our larger strategy and have that impact. Like I mentioned, we want to bring better data analytics, vendor support where we can, and resources, and aligning our priorities, and then also just engaging other stakeholders. So when you are having your discussions, there is some of that public comment and feedback and the other folks that we can bring to the table to really inform a lot of the decisions and recommendations you will be making. Next slide. So our focus area for the coming year at the Health Authority that we really would love some help on, and one of the reasons I wanted to bring it to this group, hold on, my throat's starting to scratch again, is because of your expertise on this group. There's a lot of great, I think, clinical background, systems background, and one of the areas that we know that we want to prioritize with the governor and others is maternal infant health. As I mentioned, we are really ranking poorly, and it's not just about care delivery, it's also about workforce. There are a lot of issues here that are impacting these outcomes, and we really need the help of this committee to drive home really true solutions that we can bring to the legislature next session, as well as what we can start doing now. I think, I prefer not to wait every 2 years to start moving new ideas, but I also want to recognize some of them do require statute and funding, but there are, I think, things that we can be doing better now and helping look at the data so you guys can help us identify with your expertise what we should be focusing on. Because we can be focusing on prenatal care and missing something even bigger, right? And it is prenatal care, but what piece of prenatal care? Why is it a problem, for example, in our state? And this really builds on a lot of the work and momentum we have right now with Medicaid that we're trying to do with the federal government too, and really expanding value-based payment design, rewarding those providers and systems that are focusing in on improving outcomes for moms and babies. And, it really aligns, I think, too, with the PPC with access, quality, and affordability of coverage for moms and babies and this population. Next slide, please. All right, so Dylan, do you want to walk through this since it's the high level work plan that you're kind of going to be proposing for the commission? Because I feel like you may give it better justice since this is really how you've put it together, and just want you to own that piece of it. And obviously we're excited about this rollout. So go ahead.
Sure. Over the course of the interim, I think one of the things that I would like to do is kind of gain a shared understanding of what the problems are. So clarify what are the questions and integrate what data we have available and what gaps there are in information. And then take that and do some analysis and evidence development and kind of assess what is the system performance right now and review best practices across different states and things that are happening in with this state at a local level, and then develop those policy options that we can bring forward in a BDR, but not only as a BDR. As Stacy mentioned, we want to bring recommendations that are non-legislative as well. And then produce those clear, actionable legislative and non-legislative recommendations and communicate those really clearly and engage with our legislators, our different departments. So I guess that brings us to our last slide, which is just questions you have for myself or Stacy.
Any questions from the commissioners? None?
Right.
So I
Thanks.
haven't let you get away so easy, Steve.
I
No.
know. I was gonna say, Dr. Cohen, you have to ask me one.
No, thank you so much, Stacey. A lot of hard work has gone in with your leadership in this area. It's a very complex subject. We all know that, and it's very challenging to find solutions and implement them, more importantly. One point I would like to make is, Stacy, specifically, when Governor Gwynn was the state governor, he had set up, I think, either a commission or a task force about access to healthcare at that time. And we were in the same categories of healthcare that you've pointed out at the bottom, even then. The ironic part I see is that was more than 20 years ago. And the whole purpose of that commission task force was to highlight the areas where changes could be brought in or made and what can be done, et cetera, et cetera. So my concern, obviously, is the implementation part. The needle hasn't moved. What can we do differently, in your opinion, to move the needle? I know we have a great new leadership and everything else. We have a process of the legislature, which is complex. We all know that, to make a change. Change is my biggest concern, that we just don't move.
I agree. But you know, I also, that's one thing I've been thinking a lot about, and I think why the health authority brings a different opportunity is because, you know, and also, you know, last session, there was part of the bill to move public health over next session. So we are coming forward with that next biennium. There was a report to do that for the legislature. I think by bringing public health together, by bringing Medicaid, the exchange, all the markets and areas and working on the same things with similar strategies gives us a better opportunity. I think for so long, Medicaid's been doing its great work, right? Let's focus on that population. Or PEB's been doing this, or maybe not even looking, right, at all of why are the chronic conditions different here and where should the focus be? I think we haven't truly had a population health management strategy in this state, Dr. Khan, and I think that is key. And I think until we can see what's going on across our programs, where can those strategies align? Where are the carriers doing the same thing with the providers on the same issues, like maternal health? Why don't we have the same value-based payment designs across all markets? Why, you know what I mean? Like, that's where we know we get the best value and quality, and all the work is bigger population, right? And so I think it's about having that bigger footprint that we do have now under the health authority. I'm not saying the work before wasn't right or didn't do the right, you know, implement. And I think implementation is hard. I think often we've tried to do things all ourselves at the state level. I think one of the things I love about this governor and even the legislature has been really embracing vendor resources and expertise nationally, as well as technology. I think there is a new opportunity with AI and all the different tools that we have to really do health literacy better. and not just health literacy, but health insurance literacy. So I think all of those things together and actually making sure all of our coverage programs are aligning their efforts so providers aren't jumping over themselves saying, I have to report this quality metric here and this quality metric there, that they're all aligned in a way that actually has the greatest impact. I think that that's what we're trying to do. I think it is a real story to tell that it is always the same issue. But I think that the different part now is that we are aligned as a state in our programs, and that we're sitting down together to figure out, like on maternal health, we are going to be focusing on this across all of our programs, behavioral health as well. Primary care is a priority for every program. And when we bring public health over, hopefully next session, we can look at prevention in a different way, especially now that we're losing access to federal funding for a lot of these programs. Where can we leverage healthcare reimbursement for prevention? Because it is healthcare. Screening and treatment shouldn't just be grant funded. It is a healthcare reimbursable service. So where are we better leveraging that? So I'll stop there, Dr. Khan. I could go on all day, but I hear you. I know it's a challenge that has been the test of time, but I think that I am hopeful, given this new alignment, that and also just some of the funding and resources that we have right now, that we can get make some movement, at least to the bottom. Maybe we won't be the bottom 50, but maybe the bottom 40, right? That would be, I think, a huge win just to even go up to that for the state. So I hope that answers your question and gives you a little hope, but that's kind of how we're seeing it.
Yeah, thank you, Stacey. Any other questions? Dr. Glyman, from your perspective, also being in the field?
Yeah, so thank you, Stacey. Thank you, Dylan, for everything you do. I think that Dr. Khan and I probably are the old guard who've been dealing with this stuff for a long time, and our sense
Not me, I'm the new guard.
Okay, that's right. You look so young. But I think that one of the issues that we've seen for 20 years is, why are we at 51, and what has changed and what hasn't changed? Well, what's changed is the state has done a remarkable job of trying to manage the Medicaid population, trying to manage the Medicaid budget, and try to manage the budgets we have. The biggest problem that I think I see is, why are providers leaving? Why do we have all of these residency programs? We train all these residents and then they blow out of here. And it has to do with the federal funding, and it's something in terms of the Medicare reimbursement. If you look at this state versus California, New York, New Jersey, Florida, they are getting paid 5 times what we're getting for the same services. And we are still being penalized for being a small state that had a population in 1980, which now our state is 5 or 10 times bigger. And the providers at that time would come here because they could make it up on volume, because it was cheap to live here. But providers are now leaving because they're not getting paid what they're getting paid in California, and it's almost as cheap to live in California. Then they're going to leave for lifestyle issues. So that's a federal issue, and that's how we get out of the bottom. Is we have to figure out a way to get Medicare to raise us up to a different level, so that we're on the same par with some of the other big states around the country. And that's not necessarily your problem. I know I've talked to the governor about it, and I think that that's something that would certainly have a huge impact in getting us out of the bottom, because it would get the fundings here, or at least make the state more attractive to get providers here that can provide the services to this underserved population.
Yeah,
Thank you, Dr. Glyman. Anybody else? I saw somebody raise the hand.
Hi, this is Travis Walker. I couldn't agree more with Dr. Glyman. I absolutely, we're an underfunded and understaffed workforce when it comes to healthcare. But I think building up that workforce is going to take time. I mean, when we look at the healthcare finance, we look at the schools, the residency programs, those are going to take, I think, a lot more time than would really be available to solve the immediate issues that we're running into. I think one of the things that we run into is really fractured healthcare system nationally, and it's very difficult to operate from organization to organization, difficulty with getting information. And I appreciate Dr. Chastain being on this committee now, because one of the things that I run into on a regular basis is medical records not being transferred easily from one facility to another. And in many cases, we're still relying on fax systems to get that information from one provider to the next. I know AB7 was intended to help with interoperability for electronic medical record systems, but is there something that we can do to give that more teeth to really encourage mandates related to whether or not a patient got a lab in another healthcare system that I can more easily get access to, or more easily flow medical records from one facility to another. And oftentimes it's really dependent on the organizations themselves to buy into the HIE or to build in their own APIs with other organizations. And that can be difficult and expensive, especially for smaller organizations. I did have a second point. I just wanted to ask you, Stacey Weeks, when we're talking specifically about maternal and infant mortality, is there more that is on the horizon when it comes to building out PRAMs or PQCs, or perinatal quality collaboratives for the state, so that we have better monitoring and data when it comes to how we're performing in that area?
I think those are the kinds of recommendations we're looking for from you. So we can push for those things. I know that there is the opportunity to do that, but the more we have strong recommendations from a group like this, the more I can get resources and funding to do that with public health when they come over. So I think that's why we want to say, like, what do you think we need besides Medicare? I appreciate that comment, but I cannot control federal government. And I think we can do the best that we can at the state level with what we have. And I think the perinatal quality collaborative is one example of a gap that, we could go seek funding for next session. We could really develop that, or get the MCOs to invest in that. There's a lot of opportunity there. But I think we need to know, is that the solution? What is it that you think could help us? And I think that's where Dylan, bringing the data that we already have, I think we would like to share with you. I know that a lot of you, with your experience in this, understand a lot of the problems, but the data often tells a different story. And we want to make sure that you see the data that we see, and can kind of give us a sense after you see that data. Would you make the same recommendations, I think, is the question we have for this group. I'll stop there. Hopefully that answered your question, but I would love to do more on that perinatal quality collaborative.
Thank you. I think I saw one more hand up.
Yeah, it's Adam Porth. I do think, honing in our focus on one particular area like maternal and infant health is helpful to just kind of focus our efforts. I mean, if you look at the microcosm of RSV vaccination rates, I mean, I think that that's something that we can affect. I mean, maternal vaccination rates are I think we're last in the country there. Our ability to give the RSV antibody to babies after they're born is also not real great. Some of that is just mechanistic, right? I mean, today that maternal vaccine has to be given through the pharmacy benefit. And so I think that there's ways that we can look at what are the systems that we have in place. Also, to the point of interoperability, when babies are born, what's our ability to even know that a maternal vaccination happened or not? I think that there are gaps in our ability to even recognize those things. So, I think having this focus in maternal and infant health is super helpful to just kind of focus in on what are things that we can actually operationalize.
Thank you, Adam. Any other commissioners? So I have a comment. I think what, in my opinion, should happen is, and Stacey, with your help, if we know from the data which areas, one or top two, for example, we have talked about maternal health, mental health, et cetera, physician reimbursement, access, and all that stuff. What would be the top two items that would be most impactful for the community that has the potential of going through? The governor has expressed his priority in his original letter to us to focus, for example, even on the reimbursement side. Of course, that it always comes to reimbursement and physician and all that stuff. But if we declare a health emergency, at least, and then focus on a couple of items, and everybody's honing in into that, the governor, the legislature, we would have some hope of making progress. But Stacy, from your perspective, which would be the couple of areas that the commission could really focus on, spend a lot of time, come up with the recommendations, and hope it gets through the legislature if it has to?
So the governor's letter was for last session, just to be clear.
Yes.
And we have a lot of work in the workforce area. I'm not saying that this maternal health issue isn't a workforce problem. I think we should be making sure that some of that is overlapped and it, informed this discussion. Under the statute, the director, so my position does direct sort of the focus of this commission going forward. I would really appreciate if the help on maternal health. Like we have a lot of efforts and resources focused on behavioral health. We have a lot focused with a lot of money coming in, which is amazing, on rural health. We could use help on the workforce stuff. Like what would you guys recommend on the maternal health side, right? But no one, I'll be honest, at a high level prioritization is really focusing on these really alarming outcomes for our moms and babies. I do think we can have an impact on that. The state serves and covers 1 and 2 moms and babies on Medicaid. So, and I think even some of the comments Adam was making, like, where can we have a real impact and have some success with this commission in the session so we can actually show that we're moving the dial. So we're trying to put together strategies around this. And so that's one of the reasons we wanted to say we really need your help in this space. And Dylan's got a lot of research and data to share. I know Dr. Chastain's got a lot of stuff he can help us kind of really outline. And then if you guys can make recommendations to us so we can take them to the governor too, to be like, if we do these things next session, we can actually make an impact. Because I think that we all could use some of those outcomes. So that is why we brought that. And I looking at your expertise too, I feel like this is a good group to do that. Not to say workforce isn't an important issue, but I would appreciate it be focused on what are we doing around moms and children and infants? And maybe primary care is still part of that conversation too. So hopefully Dr.
That is very helpful because we really need to focus as this commission on a subject that, like you said, could be most impactful. And if this is what it is, then we as a group should prioritize that as the item number 1. And there could be an item number 2 and 3, which we would need your help also from
Absolutely.
the data people. Okay, number 1 is this, number 2 potentially is this, and number 3, and then we can deliberate for BDRs, etc. Any other comments from the commissioners?
Could you send us all the information on your recommendations so that we can give you a data-driven opinion or a guidance so that we can take a look at it and give you some type of academic thought on what would be the best way moving forward?
Yes, Mark, there's a whole, like every meeting, I think we're going to be laying out a lot of, Dylan, do you want to walk through the work plan a little bit? Maybe that's like.
Yeah, and it's not fully
It's not all
fleshed out.
today. Yeah, I think we're just laying out.
It's not fully fleshed out, but the first few meetings will be kind of gaining that shared understanding of what's in the data. So bringing together what literature there are and having presentations about what's out there right now. And then we'll move into defining, all right, what are the biggest problem areas that we can impact as a commission?
All right. Thank you. Any other comments before we move to the next agenda item?
Just one last thing. I mean, could you just email us all of that information so we can get up to speed? So we're
Absolutely.
looking at it and are more prepared at the next meeting, so we can sort of focus on the maternal and child safety issues. And then if we're going to be able to come up with some recommendations, we're looking
Absolutely.
at it at the same level as you guys, or maybe with different eyes.
All right. Thank you very much. This was a very helpful discussion, I think, to move forward. Going on to item number 5 for information, the 36th special legislative session update. Dylan, you have the update?
Yep, moving on to agenda item 5, this is an update on the 36th special legislative session, and some of this kind of dovetails with conversations that we just had. So I'll start with Senate Bill 5, which is a comprehensive healthcare access measure. It incorporates sections of SB 434 and portions of the governor's healthcare bill from last session. It focuses on identifying statewide workforce shortages, supporting targeted recruitment efforts, and improving administrative processes for how quickly providers can begin practicing in Nevada. It establishes the statewide healthcare access and recruitment grant program, which is referred to as SHARP, and it creates a competitive grant fund within the Nevada Health Authority to address provider shortages or gaps in clinical expertise identified through a new biennial statewide workforce assessment. And then Section 19 of the bill sets new expectations for hospital privileging timelines. They must process at least 95% of complete requests within 60 days. If a request is incomplete, they must notify the provider within 15 days. Hospitals are required to submit an annual report with their average processing time, their compliance rate, and any planned improvements to that privileging process. Sections 30 through 34 focus on credentialing and licensure. The medical board and osteopathic board must prioritize applications from providers who intend to work in those shortage specialties or areas identified through that statewide assessment. The bill also updates immunization requirements by aligning them with federal immunization standards and recommendations in effect on January 1st of 2025. And it authorizes the State Board of Health to modify or add to those standards through regulation. Then Senate Bill 4 was an appropriations bill with a couple different healthcare related components to it. It includes funding for hybrid healthcare kiosks in state correctional facilities, and funding for jail-based behavioral health programs in Clark and Washoe County. It also appropriates funding to improve technology used to reduce SNAP errors. Under HR 1, the Federal Reconciliation Bill, states with a payment error rate above 6% will need to cover a share of SNAP benefit costs, with liability reaching up to 15% of total benefits. Nevada's error rate typically hovers around the 6% mark.
Any comments on this?
Sorry, there's a little bit more. I just pressed the button.
That's fine.
The bill also supports the Nevada Health Authority related to the public option. It provides funding for broker compensation, and then to assist in enrolling in the public option. Alongside that, it establishes a community outreach and enrollment grant, which will be awarded through an RFP process to community-based organizations that help people understand and enroll in Medicaid and the public option. It also funds certain public health and education infrastructure. Now I can open it up for questions, Dr. Khan.
All right. Go ahead. Any questions, observations from the commissioners or others?
Yeah, this is Adam Forth. Just a little bit more color on the immunization section of SB 5. Really, part of that is to allow the state some flexibility to advocate for immunization, maybe more broadly than the CDC might be recommending. So kind of locking in place what those recommendations were at the beginning of the year, and then giving some more local authority around what immunization recommendations we would make at the state level.
So a quick question. Given the changes coming in at the federal level with the immunizations and ever-changing dynamics, what authority does the state have to do differently versus the federal guidelines? Are we mandated to follow federal guidelines, or the state has any leverage to implement its own guidelines?
I think that section of SB5 provides a little bit of flexibility, but Stacy may be able to provide a little bit more clarification.
Yeah, we can follow up in writing, Dr. Khan, but the whole point is to give the Board of Health the ability to help address those issues. So there is
Okay.
a path. Mhm.
All right, perfect. All right, thank you. All right, any other comments? If not, we can move to the next agenda item, is the approval of the minutes. Do I have a motion to approve the minutes? I presume everybody has had an opportunity to go over them. Any changes, modifications, corrections? If not, could I have a motion to approve? And second?
Motion.
Second.
All right. Any opposed? If not, the motion carries. Number 7 item is the review and approve the updated bylaws for PPC. Now, they were also distributed to all the commissioners, and we need to know if there are any questions from the commissioners to the proposed bylaws. If no questions, I would request a motion to approve the bylaws.
Motion.
Second, anybody second?
Second.
Thank you. Any opposed to this motion? If none, the motion carries. Thank you very much. Going to item number 8 is the review and approval of semi-annual PPC report required per NRS 439918. Now, we have had access to this also. This was sent to us before. I am, again, presuming everybody has had a chance to review this so that we can deliberate and move forward. So has everybody had a chance to look at this? Okay,
Yes.
so then, okay, great. So I'd like to have a motion to approve this report.
Motion.
Any second?
Second.
Thank you. Any opposed to the motion? Motion carries. Thank you very much. Back to the last agenda item on public comments. Dylan, do we have anybody in the public comments in person or any comments received in writing?
At this time, we will move to public comments. Anyone wishing to make public comment by phone, you may join the meeting by dialing 775-321-6111. And when prompted to provide the meeting ID, enter 204-345-574#. Please press *5 to raise your hand during the public comment period to provide your comments. Comments will be limited to 3 minutes per person. Persons making comments will be asked to begin by stating their name for the record and spelling their last name. If you wish to make public comment by phone, please press *5 to raise your hand. Joining by the computer, please use the raised hand icon at the top of the screen. Chair, I see no one wishing to make public comment at this time.
All right, thank you. So having said that, anyone has any item to bring? Otherwise, we are ready to adjourn. If not, I need a motion to adjourn.
Motion.
Any second?
Second.
Any opposed? Well, the motion carries. This has been the shortest meeting ever since I've been on the commission, so I hope we can keep the trend going. All right. Thank you very much, everyone, for your time and effort, and we'll see each other in the next meeting. Thank you very much. Thank you.
Thank you.
Thank you.